Okay, perfect. All right, and then just let me know when you can see my screen.
You are on the main screen now.
All right, perfect. Good. So you should be able to see this one that says basic antibiotic principles, right?
Yeah.
Yes.
All right, wonderful. Okay, so as we go through these slides, the goal is not to read the slide to you. It's to basically talk about how you approach the questions for the test, okay? And how you can remember the information. So in this first one, when it's talking about basic antibiotic principles, this is not high yield, okay? So let me just tell you that. They're not going to ask you these basic antibiotic principles. They don't care about that. They do want to know, however, if you're prescribing an antibiotic, how long is the course of that antibiotic? And then what's the correct dose? Okay, everybody follow me there?
Yeah.
All right, good. All right, perfect. So let's start off with a little warm up. And let's go with, let's see, Dr. Everett, go ahead and tell us this question and give us the answer.
I would prescribe here ampicillin.
Which one?
Option A. Ampicillin.
Okay, ampicillin.
Yeah.
Okay. Uh-oh, somebody just checked in. Okay, that's the only disadvantage to when I share my screen. When somebody checks in, I'm going to have to let them in. Hopefully that's the last person. I think it is. Okay. All right. Did they get in? All right, there we go. All right. Is there a way I can do this without getting out? Okay. All right. So you said that let me make sure. So you said that the letter is A, correct?
Absolutely.
Okay, hold on.
This is my choice.
All right, hold on. Let me make sure I get everybody's name. So, because I will be calling on people. I want to make sure I see who's here. Sophia's here. Okay. Pinka. Travani. Pooja is here. Anna and Richard. All right, got it. All right. All right. So let's go ahead and go back to where we were. Okay. And so everybody should see this screen right now. And so just recap for Anna. So you said the answer choice for you was answer A. Is that correct?
Yes.
All right. I'm going to ask, does everybody agree with that?
I think amoxicillin would be a better option.
Okay.
I would
So
choose amoxicillin also.
Amoxicillin.
Did you say ampicillin?
Amoxicillin.
B.
Okay, great. B. So let's discuss this. So the key here, so the answer to this question is amoxicillin. Okay. Now, the major difference though, what's the major difference between amoxicillin and ampicillin?
IV. Oh no, hold on.
Yeah, no, perfect. So
Dosage.
And
yeah,
I think one is IV, ampicillin is IV.
So the major difference is how it's administered. Okay. So if somebody can take something by mouth, if they can take it by mouth, what are you going to give them? Amoxicillin or ampicillin?
Amoxicillin.
Perfect. So if they're able to take it by mouth, you give them amoxicillin. Now, if they're not able to take it by mouth, you would then give them what?
Ampicillin.
ampicillin.
Exactly. Now, there's something else wrong with this ampicillin. What else is wrong with that ampicillin?
The dosage is wrong.
TID.
Correct. Exactly. That's right. So the best antibiotic for this patient would be amoxicillin. Now, question: what do you see right here? What is this?
Abscess.
Sinus
It
tract.
is an abscess. Very, very good. It is an abscess. So what's the major cause? What's the major bacterial cause of an abscess?
Anaerobic bacteria.
Okay, such as? What's an example? So
Porphyromonas,
you can have a staph,
staph.
right? Any right,
Yeah.
good. So basically, anaerobic bacteria, staph would be one of the ones that can also cause an abscess. So the key to this one is amoxicillin. Okay, these are just warm-ups right now, so don't worry. These are just warm-ups. All right, next question is for, let's go with Dr. Richard.
May I ask a question here?
Yes.
In the same question, in the previous question.
Okay, let me
So
get back
since
to
they
that.
gave erythromycin as one of the options,
Wait, let me go back. Let me see if I can get back. Yes, so you see, so you said what about erythromycin?
they gave erythromycin as one of the options.
Uh-huh.
And only if the patient is has penicillin allergy, we would go with that option in this question. And
Correct.
otherwise, just because since there could be mixed bacteria in there, erythromycin could also be one of the options, but it's a broad spectrum of activity. So that's the reason we are choosing with amoxicillin. Is that how we should remember it for answering the questions?
Right, exactly. So amoxicillin and ampicillin are both what we call wide spectrum antibiotics. They cover a lot of different things. Erythromycin would be a viable option if they were allergic to penicillin.
Mm-hmm.
But since there's nothing, so in the question, that's why you have to make sure you look at this right here. It says no allergy. So that was a giveaway that they could take a penicillin.
Right.
Okay.
Doctor, I have a question seconding Deepika's. So if there was supposedly an allergy to penicillin, wouldn't clindamycin also be like a good option for it?
Clindamycin in the past has always been the second option. But the problem with clindamycin is that now you get a lot of problems with pseudomembranous colitis.
Okay.
And that pseudomembranous colitis has really taken it away from being used as a prophylaxis. So in the past, you would always see it being used as a prophylaxis, like when you needed like some type of prophylaxis.
Okay.
But it's no longer in the protocol.
Okay.
Okay. I have to
Yeah.
let one more person in.
Thank you.
All right. Great question. All right. I just had to let someone else in. Let me make sure they got in. There we go.
Thank you.
Absolutely. Absolutely. All right. Let's go to the next question. I think I was asking Dr. Richard for that one. All right. Can you hear me, Dr. Richard?
Yes, I'm here.
All right. All right. So what is let's get to that next question. Okay. All right. What's the answer to that?
I'm not sure.
Okay. So what's the question asking us?
The question is asking the mechanism of action for the antibiotic used for this patient.
Okay. And do we know the antibiotic we used?
It was amoxicillin.
Good. So the question is really asking us what?
How amoxicillin works.
Right. Exactly. So what's the mechanism of action of basically a penicillin, right? So from that question, what's the mechanism of action for penicillin? Do any of these choices stand out for you?
No, I wasn't able to review this this lesson. I was preparing for my reb exam, so
Got
I was a little
okay. All right, no problem. All right, let's go to Dr. Pooja. Can you tell us?
It inhibits beta lactamase.
Inhibits the beta lactamase. Are you
Yeah.
okay? So that's your
Yeah.
answer. Does everybody agree with that?
Yes.
Okay, I got one person says yes.
When I chose
I think it's the
if it's ampicillin, I
cell
was
wall.
Okay. All right.
The beta
Dr. Edward, what'd you
lactamase.
say?
Well, the beta lactamase would it be augmentin? Wouldn't it be more with the clavulanic acid?
That is true. That's true. Who says that?
So
I can't see faces while this is up. Who said that?
with Anna.
Anna. Okay, you are correct, Anna.
So I think maybe
C.
choice C.
Well, guess what? The answer is C. It is C. Very good. So you're correct. The beta lactamase, the inhibitor of beta lactamase, is like clavulanic acid. Okay, so that would be like what you would find if you mixed, say, amoxicillin with clavulanic acid. That would give you augmentin, but that is inhibiting the beta lactamase. That's true. What about this one right here? What blocks the 50S ribosomal subunit? Does anybody know a possible answer choice for that?
Cephalosporins, group of drugs.
Cephalosporins. Very good.
Clindamycin.
Are you sure it's a cephalosporin? Now, if I write this, that doesn't mean it's correct. I just wrote it because you said it, but does that mean that's correct?
Wouldn't it be like, well, 30C and would be for the Bactrim, yes, sulfanilamide.
Okay, so we're going to learn this in just a second. I think you did remember cell, but the cell would be like clindamycin.
Okay.
Right. So cephalosporins work almost like a penicillin, which we're going to see that in just a second. Okay. But anyway, these are just warm-up questions. Don't worry. These are just warm-up. Okay. Let's see here. Let's go with let's see. Dr. Sophia.
Yes.
All right. What's the answer to this one?
Hold on. That one is this question I wasn't sure, but I know that they prescribe it for pediatric patients for sure. Maybe oral contraceptive.
Okay. So you said you think the answer is A?
Yeah.
Okay. So let's look at the question. The question is asking, what is the question asking you in your own words? What do you think it's asking?
The
What conditions are
contraindication,
strictly
yeah.
Wait.
indicated
Hold on
for-
1 second. Hold on. Let me just stop you. All right. So whenever I'm asking one person a question, if you could mute your mics, because I think I'm hearing background information or I think somebody's trying to interrupt. So make sure only one person is talking at a time, okay? This is Dr. Sophia's question.
Like it's basically asking me if the patient have one of those condition, if it would be strictly contraindicated amoxicillin, like what is amoxicillin I couldn't use if the patient would have one of those conditions.
All right. I love it. That's perfect. Great. So your answer, so let's look at what you put. You said that if a person is 25 years old and they're taking an oral contraceptive, it would be contraindicated. Is that your answer?
I'm just guessing.
Okay. All right. That's okay. So now I'm going to open it up to the group. Does anybody else have another option?
I have option D.
Option D.
All right. I think I heard two people say option D as in dog. Is that correct?
Yes.
Yes.
All right. Okay, good. And why did you choose option D?
Well, the choice A, I don't see any contraindication for use of contraceptive. Choice
Okay.
B, warfarin between 2 and 3 is normal. Choice
Good.
C, you can use it in the pediatrics, so it's choice D. Because if it's Stevens-Johnson's after treatment for syphilis, so it's probably Bifilin or, some kind of,
They tend to have some
Yeah.
kind of heart problem, I guess. So it is a chance that
penicillin.
they know for people with Steven Johnson's.
Okay. All right. So I love how you said that. You both said it correct. So basically, because this patient had a reaction to a previous reaction while they were being treated for syphilis. So syphilis is treated with penicillin. So basically, the individual had a reaction to the penicillin. So since they had a reaction to the penicillin, then it's strictly contraindicated for the amoxicillin. Does that make sense?
Yes.
Yeah.
Okay. All right. Dr. Sophia, that makes sense?
I'm sorry. They strictly because they had the reaction.
Yeah. So you see that this patient in D was previously treated for syphilis. You see that?
Yes, I see.
Uh-huh. And then the way they treat syphilis is with penicillin. Okay. Now, when they were treated with the penicillin, yeah. So when they were
Yes.
treated with the
Yes.
penicillin, you see what happened, right?
Yeah.
So that means that they were allergic to penicillins. All right. That makes sense?
Makes sense. Yes.
All right. Good deal. All right. So now let's jump right into these antibiotics. Okay. So in pharmacology, for the test, you always got to know the use, what do you use it for, the mechanism of action, side effects, possibly you might need to know the dosing, and if there's any contraindication. Those things you got to know. All right, everybody follow me?
Yes.
Yes.
Okay, good. So as we go through this, make sure that we're answering these questions, okay? So the first one is pretty easy because we're talking about cell wall inhibitors. When we say cell wall inhibitors, we are talking basically about a mechanism of action. So out of the ones you see here listed, the ones you need to remember for sure are the penicillins, cephalosporins, maybe vancomycin, because sometimes they ask you about that. But those three are the major cell wall inhibitors. Okay, so what that means is this. Bacteria have a cell wall. We do not have a cell wall. We have a cell membrane. So that means that if you have an antibiotic and it targets the cell wall, that means it will be good for killing the bacteria and not really causing harm to us. So the cell wall inhibitors, we use this mnemonic. You can come up with your own, but this is one that I've used before in the past. But it goes like this. My sister, which is the amino acid cysteine, her name is Val, that's for the amino acid valine, got a nice ring from her fiance, Vic, when he got back home from Arizona, which is AZ, and bought her a house with beautiful ceilings and no walls. Now, let me explain this mnemonic, okay? So basically, cysteine and valine are amino acids that are structurally needed for penicillin, okay? So let me put it like this. So penicillin has what we call a beta-lactam ring. And this is what a beta-lactam ring looks like. All right, so this is the structure for penicillin. Looks like a little house, right? So the components of that house are cysteine and valine. Now, that's where we get these two from. Got a nice ring, beta-lactam ring, from her fiance, Vic. That's the vancomycin, imipenem, cephalosporins, and cycloserine. That's the Vic. Bacitracin. Now, bacitracin is not going to be something that you're going to be using like clinically. That's something basically they use in the lab to identify bacteria, okay? And aztreonam is not one that you're going to see on your test, okay? So the only ones you need to remember that I could definitely tell you, penicillin, cephalosporin, vancomycin. Is everybody comfortable with that?
Yes.
Okay,
Yes.
perfect. Now, if penicillin and cephalosporins both have the same mechanism of action, why would I use, say, a cephalosporin rather than a penicillin?
If the patient is allergic to penicillin, we could use cephalosporins.
There you go. It's all based on allergic reaction because they have the same mechanism of action, right?
Yes.
Good. Now, let me ask you this question. What if a patient was not allergic to penicillin and they could have the option of taking a penicillin or a cephalosporin? How do you decide which one to give them?
Can we test it on the patient, like small doses,
No,
to check
you don't
if
want,
he's allergic?
you don't want to do that.
We should know which bacteria is susceptible to the antibiotic.
Most common.
Ah, right. So it's more determined on the bacteria present. So like if it's a cephalosporin, depending on which cephalosporin we use, it's going to have a specific target. Like it might target Haemophilus influenza, it might target E. coli, but knowing or having a good idea of the particular bacteria lets us know which one we want to use over the other, okay? And we'll talk about that later, but that's what you look at there, okay? Now let's talk about these penicillins. So on the exam, they do want you to know the difference between Pen V and Pen G, okay? Now, why is Pen V oral? What makes Pen V oral? Why can't you just give Pen V IV or intramuscular?
Can be absorbed in the stomach.
It can do what?
It can be absorbed in the stomach because of the hypochloric acid.
Okay. So you said it close, but is it is the question, is it
No,
absorbed?
It's not absorbed. It's resistant. I guess.
Well, okay. So Pen V basically in order for Pen V to work, it is metabolized in the stomach, right? It's broken down in the stomach because of hydrochloric acid. That's what you were looking for, right?
Right.
Good, perfect. So Pen V is oral because in order for it to work, it has to have the hydrochloric acid that's in the stomach to help break it down. Now, Pen G, on the other hand, you remember we were talking about syphilis earlier? So syphilis is typically treated with Pen G, like benzathine, which is basically an IV or intramuscular medication for syphilis, okay? So this mnemonic is just a crazy mnemonic that one of my medical students came up with years ago, but it said that basically people who drive Benz, like Mercedes-Benz, have big muscles and syphilis. That's not true, but it's an easy way to remember the question. So when you see Pen G, I want you to think of Pen G is the person driving the Mercedes-Benz. And this person has big muscles, but they also have syphilis. Got it? All right, everybody with me?
Yes.
All right,
Yeah.
perfect.
Yes.
Okay. Now, believe it or not, these crazy mnemonics that I'm giving you, when you get to your exam, you're going to say to yourself, you're going to hear my voice at the exam with these crazy mnemonics, and they're probably going to help you out. Okay. Now, next thing. So we talked about ampicillin and amoxicillin, right? Ampicillin and amoxicillin. And we said that these are wide spectrum antibiotics. Now, that means that these things can cover a lot of different things. Okay. The only thing that I want you to remember from this slide are a few things. One, amoxicillin is given how? How do we give amoxicillin?
Oral.
Perfect. Very good. We give ampicillin if they can't take anything by mouth. Okay. Now, do you see this MO in amoxicillin? Think about MO, otitis media. Okay. So that's like an inner ear infection. So one of the treatments for an inner ear infection, other than like we treated for abscess also, is amoxicillin. Okay. Now, the other thing with amoxicillin, and we'll put a star by this one, is that it can interact with methotrexate. Now, if it interacts with that methotrexate, it can cause oral ulcers. All right. I would remember that one for the exam. Now, this down here at the bottom, you do not have to remember each one of these, but here's what I would tell you. In terms of microbiology, there are just certain things. They don't ask a lot of those questions like they used to do on NBDE Part 1. Most of the micro questions are going to be in your perio section, okay? So you're not going to get a lot of like questions about salmonella, Shigella. They used to love this question about Shigella because Shigella is responsible for dysentery. Does anybody know what dysentery is?
Diarrhea, mostly.
Perfect. Very good. Bloody diarrhea. Yeah. So this used to be a favorite on the exam. I only had one person told me they had this on their INBDE exam about Shigella. So it doesn't come up a lot. But if you do see Shigella, that would be bloody diarrhea. All right. Now look at this mnemonic. Don is skinny. He's small. Skinny meaning narrow. And he's not scared or afraid to get in the ring. Okay. So basically what these are penicillins that already have the beta-lactamase inhibition properties. So let me make sure, let me recap what I just said. So you remember how we can say bacteria get really smart. And so they start to believe that they can become more resistant to certain bacteria. So what we do is we can use what we call a beta-lactamase inhibitor for those bacteria that are starting to target the beta-lactamase. Now, did everybody understand that? Or do you need me to repeat that?
Can you repeat that?
Yes, I'll repeat that. Because as I was saying it, it sounded like I was saying it pretty quick. So let me say that again. So watch this. So you remember we talked about penicillin, right? And we said that penicillin had this beta-lactam ring, right? So here's penicillin. Well, you have this bacteria, right? This bacteria right here. And this bacteria normally is pretty sensitive to penicillin, meaning penicillin can normally kill this bacteria. But now this bacteria has gotten smart. Hold on, let me go back. And now this bacteria can go over here and it can target this beta-lactam ring. So it can become resistant to the penicillin. Do you understand that so far?
Yes.
So
Yes.
far, so clear.
Okay. All right. So penicillin says, wait a minute, if that's the case, I need to combine. So let's just say we're talking about amoxicillin here, right? So amoxicillin says, wait a minute, I need some help. So then amoxicillin gets help from clavulanic acid. And then together, they're able to defeat the bacteria. Does that make sense so far?
Yes.
Yes.
It does.
So clavulinic acid, this clavulinic acid is what we call a beta lactamase inhibitor. So it basically prevents that bacteria for destroying the beta lactam ring. Now, some penicillins, they're so strong, they don't even need clavulinic acid. They have their own interior beta lactamase. So this is where we use the word Don. Don is skinny, which is narrow. These are narrow spectrum antibiotics, and they already have the ability to inhibit beta lactamase. So they don't need to combine with anything. Does that make sense?
Yes.
Yes.
Yeah.
So Don is dicloxacillin, that's the D, oxacillin, and nafcillin. So these three are what we call narrow spectrum antibiotics, narrow spectrum penicillins. And nafcillin is good for staph. Okay? So, all right. Does that make sense?
Yes.
Yep.
It does.
All right. Perfect. Good deal. Now, remember, anytime I ask you, I say, does that make sense? That means it makes enough sense where you can teach it to someone else. Okay? Now, this next thing we're looking at is the IV penicillins, IV. So you get in my car to meet IV. All right? Get PNG, we know that's IV, in my car, carbenicillin, to meet methicillin, IV. Those are your IV penicillins, okay? So we could have easily added what other penicillin? What other penicillin could I have easily added on here that starts with an A?
Ampicillin.
Very good. So I could have easily added ampicillin here as well. Did everybody see that? Okay, everybody with me?
Yes.
Yes.
Okay, okay, perfect.
Yes.
Now, if we look at the oral penicillins, oral means by mouth, right? So think about this fish called a codfish. That's a type of fish. It goes from the pan where you cook it to the mouth. So codfish goes from the pan to the mouth. The mouth indicating oral. That's the cod, C-O-D, cloxacillin, oxacillin, dicloxacillin. Pen V, we know that's oral. Now, here, this is probably going to confuse you a little bit. Ampicillin and amoxicillin. Now, what did we just say about ampicillin?
IV route of
It's
administration.
taking IV. Yeah.
Right. So what do you know? So now what do you know about ampicillin?
It can be taken both orally and IV. Yeah.
Exactly. Very good. Very good. Exactly. So it can be given both ways. All right. And what do we say nafcillin is? What type of antibiotic is nafcillin?
Orally.
Narrow.
It's a what?
It's a narrow spectrum.
Narrow spectrum. Okay, good. And what about its beta lactamase activity?
It doesn't affect. Yeah. It doesn't need.
It already
mean-
has clavulanic acid.
Well, it doesn't have clavulanic acid, but it already has the ability to
It doesn't
inhibit
need-
beta lactamase.
Yeah.
Okay, that makes sense?
Yes. Yes.
All right, we're going to come back to the A's to C's in a second. Don't worry about that right now. So don't worry about this. They're not going to ask you that. Okay, now let's get to our cephalosporins. Cephalosporins, C-E-P-H. All right. Now, we already know the mechanism of action, right? How do cephalosporins work?
Cell wall inhibitors.
Good. Perfect. Now, What is the cell wall made of a bacteria? Does anybody know what it's made of?
Proteoglycans.
Very good. Perfect. Peptidoglycan. Right. So instead of cell wall inhibitor, if they put on your exam inhibits peptidoglycan, right? Do you still understand how they're still talking about cell wall inhibitor?
Yes, it would say peptidoglycan synthesis, right?
Exactly. Very good. Which would imply they're talking about the cell wall. Okay, very good. Now, look at cephalosporin. It evades beta lactamase. What does that mean?
It doesn't require the beta lactamase inhibitor.
Say it
But
again.
it works around the beta lactamase. It doesn't require it for its function as such.
Right. So this one does not require, it already has beta lactamase inhibitory properties. So just like those narrow spectrums we looked at, like nafcillin, you don't have to add a beta lactamase inhibitor to this. Does that make sense?
Yes.
Okay. The P, it's an alternative, penicillin alternative to staph. So if somebody's allergic to penicillin, cephalosporin is a good backup. And of course, hypersensitivity reactions. Now, let's talk about these cephalosporins for a second. The way you look at this on the exam is being able to identify if something is a cephalosporin. Most times, if you see the word ceph, either CEPH or CEF, it's a cephalosporin. Okay, does everybody understand that?
Yes.
Yes.
Okay.
Yes.
All right. Now, the next concept, listen to this closely. Whenever they started and they discovered cephalosporins, the first generation only covered a few things. As they started through the years producing more cephalosporins, like the fourth generation and now the fifth generation, those things could cover more things. So what am I saying by saying that? The first generation doesn't cover as much as the fifth generation. But the first generation, the second and the third generation are still recommended for things that are very common. Okay? So let's talk about these. The first generation cephalosporin are the rich girls. These are the girls from Hollywood, California. Their names, these are sisters. Their names are Zoli, Roxy, and Lexi. That's their names. They're the rich girls. All right. And they're irreplaceable. Okay. So what do I mean by that? Cefazolin, that's Zoli. Cephalexin, that's Lexi. And cefdroxil, that's Roxy. Okay. Those are your first generation cephalosporins. There's no way on the exam they're going to ask you the difference between one of these because they're all first generation. So there's no answer choice that they're going to give you where both of these or all three of these will be in the same answer choice. Does that make sense?
Yes.
Yes.
Okay, perfect. That's the key. That's something to remember. Now, if you, this is so cool. Watch this. I'm going to teach you something major. Say you have an answer choice, right? A, B, C, and D. Answer choice has cephalexin. Answer B has cefazolin. C has, let's see, ampicillin. And then D has, let's see, rifampin. Okay? Now, you have no idea what the answer choice is. You have no idea what the question is, do you?
No.
No idea. So if you have no idea what the question is, could you answer this? Could you give me the correct answer?
How's it possible?
Maybe.
You said maybe. All right.
It's probably C or D.
Yes.
Depending on the-
Yes. You are correct. It is C or D because you're going to eliminate A and B because A and B are in the same category. They're both first generations. And you cannot pick one over the other, right?
Yeah.
So that means that you've already narrowed your choices down to either C or D. So now if I were to tell you that this patient was suffering from TB, right, tuberculosis, could you give me the answer?
D.
Rifampin.
Rifampicin.
Yeah. But the ideal here is not for you to memorize that rifampin treats TB. The ideal here was to teach you how do you approach a question and eliminate answer choices. Do you all follow me?
Yes.
Yeah.
Okay, perfect. All right, good. All right, so that's first generation. Now, second generation is Anna. It's all about Anna. Now, you all may not know Anna, but there used to be this star a long time ago named Anna Nicole Smith. She married this old rich guy, right? Anna, she loved very expensive things. And she got this fur, which was a fox fur, like a fox fur coat, right? And that was Anna. Anna, she didn't really like the fox fur, but she had one. Now, what does this mean? Second generation, think about Anna Nicole Smith, the rich person, the rich lady who had the fox fur. So this is Surfoxine, that's the fur. Here is Surfoxetin, that's the fox. And these are good for who? Anna. Does everybody understand second generation?
Yes. Yes.
Yes, sir.
Okay, perfect. Third generation, think of the letter T. T in the word third, right? So T in the letter 3. I have to fix the T in 3 because the T is a little crooked. So I have to fix the T. Cefixime, the T, ceftriaxone, tri means 3, and cefotaxime. So if you look at those are pretty easy to remember, right? You have to fix the T in 3. Now, the beauty of these is that you already know how to answer the question on the exam. Because the only time that they're going to be asking you about a cephalosporin is either somebody's allergic to penicillin or there's something specific they're asking you about the cephalosporin, like a mechanism of action. Does everybody understand that?
Yes.
Okay. All right. Perfect. All right. So this is just kind of what we talked about before. You remember I told you how the first generation covered some things like Pseudomonas, E. coli, Klebsiella. But then when you get to the second generation, it covered a few more things, right? And as you keep going down, you have more coverage. That's all that means. All right. Pretty easy, right? H-trianam, I don't, to be honest with you, since 2000, since they started the INBDE, I've not heard one person tell me that they had this on their exam. I would be totally surprised if you did, but I'll just let you know that they use it for gram-negative rods, like Klebsiella. But I don't even think you're going to see it on your test. All right, now, these I know you're going to see. Protein synthesis inhibitors. All right, so Dr. Shravini, can you tell me where does protein synthesis occur? Where does it happen?
In ribosomes?
Perfect. That is beautiful. I love how you said that. In the ribosomes. And in the ribosomes, how many ribosomal subunits do they have?
They have 2. 1.
Good. And are they the same in humans and bacteria?
I am not sure. I don't think so. Yeah.
They're not. Good. They're not. So in bacteria, the large one is called the 50S, right?
Yes. Yeah.
And the small one is 30. Good.
30,
Very
yes.
nice. That's right. Now, just for knowledge, in humans, we are 60-40.
Okay.
So instead of 50-30, we're 60-40. All right. Very good. Thank you for that. All right. So we have this mnemonic: buy at 30, sell at 50. Now, you all probably looked at this already. Did this make sense to you when you saw the mnemonic?
Yes.
I heard one yes.
Yeah.
Yes, sir.
Yes.
Okay. All right.
Yes.
So nobody said no. Okay, good. So that means I can ask anybody my next question since everybody understood it. How about let's go with Dr. Let me make sure I'm pronouncing Deepika? Is that right?
Yes. Yes.
Okay. All right. Explain this to me. Teach it to me. What am I looking at right here in this slide?
Okay. Because I think an aminoglycosides act at the 30S subunit of the ribosomes, and the chloramphenicol, erythromycin, and the clindamycin and the
Linzolid?
linezolid act at 50S ribosomal subunits.
Now, when you say act there, what do you mean?
They're actually not letting they're actually creating like holes within the cell membrane, and which leads to
Cell death.
to cell death.
Okay. Well, let's talk about that. Okay, good. All right. So let me just kind of recap what you just said. So you just told me basically that you buy and sell it. So I always like to think of this just to help me remember the mnemonic. It's like, when you think about the stock market, whenever you buy a stock in the stock market, do you want to buy it high or low?
Low.
You want to buy it low and sell it high, right? So we want to buy it at like $30 and we want to sell it at like $50. Buy low, sell high. So the AT, which is the aminoglycosides and the tetracyclines, are basically targeting the 30S ribosomal subunits. So AT is basically saying we're going to inhibit this 30S ribosomal subunit. If we inhibit that, that means that protein synthesis is not going to happen. And if the bacteria are not able to synthesize the proteins they need in order to function, that bacteria will die. Does that make sense?
Yes, and it dies because the cell wall is made up of the peptidoglycans, the protein component, and that's how the channels are formed.
That's right. So the bacteria need proteins for several different functioning processes. And basically, if we inhibit that, that's a problem. So that's aminoglycoside, that's tetracyclines, right? And now, so we understand the mnemonic. So now we can go to the next piece. Let's look at the 30S ribosomal subunits. So here you see the aminoglycosides, MNO, amino, right? So side effects: muscle weakness, nephrotoxic, and ototoxic. So these aminoglycosides can affect the kidneys, right? They can cause muscle weakness and they can cause problems in the hearing. Does that make sense?
Yes.
Okay, great. Now, here's what you got to remember. Now, you know how to identify cephalosporin. You know how to identify penicillin. How do you identify an aminoglycoside? How do you know an aminoglycoside is an aminoglycoside?
The
Anybody?
suffix mycin.
Okay, good. So here's my question. The suffix mycin, right? Do all aminoglycosides have, now you see I put here MICIN? But guess what? Sometimes the aminoglycosides can go with this MYCIN. It's still mycin. You see that?
Yeah.
Now, question: is erythromycin an aminoglycoside?
No.
Oh, wow! But it still has that mycin at the end, doesn't it?
Yeah.
So guess what? That means we need to remember that clindamycin, erythromycin, those are not aminoglycosides. But we have a pretty cool way to remember what they are, right?
Yeah.
Does anybody remember the mnemonic for that?
Cell at 50.
Well, there's a mnemonic called ACE, ACE.
Yeah. Azithromycin, erythromycin, and clindamycin.
Yes.
Yeah.
So guess what? If we remember that ACE, ACE, azithromycin, clindamycin, erythromycin, right? Those are not aminoglycosides, right? Those work at the 50S ribosomal subunit. Then we can think of any other mycin as an aminoglycoside. Does that make sense?
Yeah.
So if I asked you about neomycin, where would you tell me it works? 30 or 50S?
30.
What about gentamicin?
30.
Streptomycin?
30.
Good. That's right. Because it doesn't fall under the ACE, does it?
Yeah.
All right. Is everybody with me?
Yes.
Doctor, to be honest, I didn't quite catch it.
Okay. All right. Watch this. Let me show you something real quick. All right. Hold on. Let's go. Okay. So you see, okay. So Dr. Edwards, you see this right here, ACE?
Yeah.
So that stands for azithromycin, clarithromycin, and erythromycin.
Got
They
it.
both, all these still end in mycin though, right?
Yes.
But these are called macrolides. You see that? As a group, these are called macrolides, ACE. Okay? Now, if I go back, you see these aminoglycosides? They also end with what?
Mycin.
Right. But they're not the macrolides. So if I put, for instance, tobramycin, I put neomycin, amikacin. So if I put streptomycin, all right, if I see these, I know these are not macrolides because that's not part of my ACE. Does that make sense?
It does.
Good. So aminoglycosides are going to work at the 30S ribosomal subunit. Now, tetracycline. You best believe that you're going to have a question or two regarding tetracycline. What's the number one thing that they're going to tell you about a side effect for tetracycline? Number one.
Tooth discoloration.
Yes, perfect. Teeth discoloration, right. Now, the other thing with tetracycline is you can have what we call photosensitivity reactions, like a rash. Like, say, for instance, have you ever heard when they say if you're taking tetracycline, don't go out into the sun? Have you ever heard that?
I know
Yes.
that, yeah.
Yes.
Never heard that.
And it's because of the photosensitivity reaction that you can get from the tetracycline. Now, keep in mind, there's very few instances where you would even think about using tetracycline, right? Because typically, unless you had Lyme's disease, you know what? Have you ever heard of Lyme's disease?
Sure thing.
Let me write
Especially
it.
here in America,
Yeah, exactly.
Yeah.
So Lyme disease is basically caused by a tick, and it carries this bacteria called Borrelia burgdorferi. And so this Lyme's disease basically, and my dog actually had Lyme's disease. It gives you kind of like a muscle weakness and some other things, but you have to treat it with tetracycline. Now, when you get into perio and things like that, you're going to be talking, of course, with the periodontists who are going to be teaching that, and they'll tell you about arrestin and other reasons you would use a tetracycline. We won't talk about that tonight. But basically, with tetracycline, it can touch the bone. You don't give it to those less than 8, meaning you don't give it to children, and women overweight meaning pregnant. So tetracycline is what we call teratogenic. What does teratogenic mean?
It
What is
could
the
cause
word?
defects in the newborn child.
Exactly. Very good. Teratogenic means it can affect the baby. Okay. Does that make sense?
Yes.
Okay.
Yes.
Okay. Perfect. Very good. So if I were to ask you to name all of the antibiotics that work at the 30S ribosomal subunits, could you tell me? Yes? No?
Clindamycin, azithromycin, erythromycin.
Did you say clindamycin?
Yes.
Okay, let's back. Maybe did I say 30S or 50S?
30s.
50s.
I thought I said 30.
Oh, you asked me 30s. Oh, I'm sorry.
30th.
Right. So I said, no, just, you don't have to tell me, but I'm just asking, just in general, if I were to ask you the antibiotics that work by targeting 30S ribosomal subunit, could you name those? You just say yes or no. Can you all name
Yes.
those?
Yes.
Okay.
Yes.
All right. So everybody's good with that. Okay, perfect. Okay. So let's look at the 50S. So the 50S is the one we said sell at 50. That's going to be our clindamycin, our chloramphenicol. Now, with chloramphenicol, think about chloramphenicol as like chlorine, like chlorine. And imagine chlorine is like what you put in a swimming pool, right? And imagine, think about what I'm about to say, is you're trying to teach a baby and you toss the baby in the swimming pool so they'll start to learn how to swim. And there's so much chlorine in the pool that now the baby's skin is gray. That's not true. That is not true. It doesn't work like that, but it's an easy way for you to remember it for the test. That chloramphenicol can cause something called gray baby syndrome. Okay? The other thing that it can do is called bone marrow problems. Okay? Bone marrow suppression and aplastic anemia. Now, you typically get the aplastic anemia because you got bone marrow problems. All of your, what we call progenitor cells or your beginning cells or your stem cells, all start in the bone marrow. So that's red blood cells, everything. So that means that if you have bone marrow problems, then you're going to have red blood cell problems. Does that make sense?
Yes.
Okay,
Yes.
perfect. Okay, so that's 50S. Then we just talked about the ACE, the macrolides. So we know those. Now look at the macro. The problems with the macros. You get problems walking. You can get some heart arrhythmias. You can get some hepatitis, rash, and eosinophilia. Now, the type of arrhythmias that you can get with like a macrolide typically are going to be things like maybe like a tachycardia. Okay. So you get an increase in the heart rate. And the tachycardia is normally due to, well, let me ask you a question. Let's say somebody had a tachycardia. They had an arrhythmia. How would you treat it? If somebody had an arrhythmia, how would you treat it?
It isn't anti-arrhythmic medicine.
Exactly. You use some type of antiarrhythmic, right? So you may use like what we call a sodium, like a sodium channel blocker, right? And a sodium channel blocker could be like anything, quinidine, it could be procanamide, but those are different antiarrhythmics, okay? Now, I know we're not talking about that tonight. I just threw that in there just to see if, you may have heard of them. All right, TB. All right. So with tuberculosis, what's the problem? What's the problem with TB? Anyone?
It affects the lungs.
Yes. So let's say that. So number one, we know that TB affects the lungs. All right. How do you identify TB?
X-ray.
You are correct. You are correct. That's how you confirm TB. But that's not the first test, though.
Lab
Yeah, skin test.
Right. We call it the PPD. So there's a PPD skin test, right? And
Yes, purified protein derivative.
say that again.
Purified protein derivative is injected underneath the skin, subcutaneous testing.
Exactly. And how many days do you have to wait to read it?
3 days.
How many?
3 days.
Two.
So typically 48 hours. Okay. So
Okay.
about 48 hours, you read the PPD test. If there's a red indurated area and it's a certain diameter, then you say, oh, okay, then they have been exposed to TB. That's all you know at that point, right? So a positive PPD test doesn't mean you have TB. It just means you've been exposed. Does everybody understand that?
Yes.
Okay, perfect. Now, does anybody know what type of hypersensitivity is the TB? It is what we call type 4, which is delayed.
Delayed hypersensitivity.
Right, that's a delayed hypersensitivity reaction. Hypersensitivity. And just for, and it's probably not on your test, but I always like put it, but the A, there's a mnemonic called ACID, ACID, like acid, which is, this is type 1 hypersensitivity, type 2, type 3, and type 4. Type 4 hypersensitivity reaction is delayed. Type 1 is allergic or anaphylactic. Type 2 is cytotoxic. And type 3 is immune mediated. Now, let me just tell you what this means. When we say hypersensitivity reactions, if you get stung by a bee stings you, and all of a sudden your mouth starts to swell, that happens immediately, right? What type of hypersensitivity reaction is that?
Type 1.
Exactly. The TB test, basically, once you put the tuberculin under the skin, you won't see any reaction for at least 48 hours. That means it's a delayed hypersensitivity reaction, okay? And then other types of reactions are like, for instance, if you were getting like somebody get a transplant, they might be antibody mediated due to antibodies and antigens. That would be immune mediated. All right. But for this, just remember that TB is a delayed hypersensitivity reaction. You identify it with a PPD test, and it affects the lungs. Now, somebody said it earlier, but how do you confirm TB? Somebody said it earlier.
X-ray.
X-rays.
Perfect. So you confirm it with an X-ray. Perfect. Okay. So now you've confirmed it that the person has TB. Now you have to treat them, right? So the treatment, Now, there are two ways. I like the word respi because it kind of reminds me of respiration, and respiration makes me think of breathing. So respi are the TB drugs that you can use. Rifampin, ethambutol, streptomycin, which you do not use anymore. That's not going to even be on the test. Pyrazinamide, and then isoniazid. This one and this one are the major ones to remember. Ethambutol would be just an answer choice if they were saying which of the following, all the following are drugs used to treat TB except. So then just remember respi. Does everybody understand the mnemonic respi?
It's pretty obvious. Yes.
Yes.
Okay. Okay, perfect. All right, now let's talk about this for a second. So let's see what kind of questions the INBDE is going to ask you. One, they want you to know about rifampin. Okay, about rifampin. Rifampin is all about the letter R. It revs up. The word revs up means speeds up. The P450. Whoa. Where is the P450 system located?
Chromosome?
No. Well, oh, I know what you're thinking about. You, not in genetics. You're thinking, not that. I know what you're thinking about. You're thinking about more of the intracellular with the mitochondria. Not there. The P450 system is a system, a metabolic system in the liver.
Liver.
Complement system.
Yeah, so the P450 system of the liver is what helps you to metabolize drugs. Any drug you take that's metabolized in the liver happens at the P450. Does everybody understand that part?
Yes.
Good. If the P450 is increased, that means you're going to metabolize the drug faster. Got that?
Yes.
If the P450 is decreased, you metabolize the drug slower. Now, if you metabolize the drug faster, does it mean that it's going to stay in your system longer or shorter?
Shorter.
Exactly. Does that mean you would need more of it or less of it?
More.
Perfect. All that makes sense, right? Pretty straightforward. Now watch this. That means if a patient is taking rifampin and they're taking another drug, say that's metabolized in the liver. Let's give you an example. Let's say warfarin, right? So warfarin, what do we use warfarin for?
It's an anticoagulant.
It's a what?
It's an
It's an anticoagulant, right?
Yeah.
So we use it for people that are having clots, that have clotting issues, right? Now, warfarin is metabolized in the liver. Let's say, for instance, somebody's on warfarin and they have TB and they're taking rifampin. What's the problem? Are they going to bleed more or bleed less?
Bleed less.
Bleed more.
With more, I guess.
Uh-oh, I heard two answer choices. I heard a less and I heard a more. All right. Who said less?
Me.
Who is me?
Sophia.
Okay. So, Sophia, you said that if a person is on warfarin and they're taking rifampin for TB, they would bleed less. Explain why.
Because rifampin speeds the P450, which is it means that it speeds the metabolism, and warfarin is metabolized in liver as well.
Okay.
That's why warfarin is not going to stay as long as it's supposed to be.
I love what you said. That's beautiful. So let's see if this all makes sense. So you said that if they're taking warfarin and rifampin is going to speed up the P450. You said warfarin is metabolized by the P450, which means that you're going to be breaking down the warfarin faster. which means that it's not going to stay in the system longer. So that means you're decreasing your warfarin. If you decrease your warfarin, think about warfarin. Does warfarin make you bleed or not bleed?
It makes you bleed.
So if I decrease the warfarin, am I going to be bleeding more or bleeding less?
You're gonna bleed less.
Did everybody understand that?
Yes.
Now, the ones who said more, do you all understand what she just said?
Yeah.
Okay. All right. Dr. Edwards, you got that too?
Yes.
I think Edward said more. Did you get that, Edward?
I got it.
Okay. All right. So now guess what? Rifampin is not the only, there are several drugs that can speed up the P450. And we're not going to talk about them tonight, but there's several. Rifampin is just one of them. Okay. Now, the other thing, the other side effect of rifampin is that it can give you a red urine, red to orange urine. That is a dead giveaway. If they ever put the patient had red orange urine, you better look for rifampin as your answer choice. Okay. Now, mechanism of action, rifampin. Think about the letter R. This R means RNA dependent polymerase. All this means is that rifampin targets RNA. It targets RNA. So with rifampin, remember everything R. It revs up the P450. It causes a red-orange urine. And its mechanism of action is that it basically inhibits the RNA-dependent polymerase. Everybody got that?
Yes.
Okay.
Yes.
Ethambutol starts with the letter E. The only thing you need to know about that, the side effects, is that it can cause problems with the eyes. They probably won't ask you, but I just wanted to let you know that. Pyrazinamide, the only thing that you would need to know is that it's only used to treat TB meningitis. If it's just a basic TB, like a general TB, you're going to use isoniazid, this one right here. All right. Only if it's like a TB meningitis would they even put pyrazinamide. Now, isoniazid is also known as INH. Now, the key to this, isoniazid, basically what it does is it decreases your vitamin B6 levels. So if it decreases your vitamin B6 levels, if you're taking INH, you have to make sure that the patient is also given vitamin B6 to help replenish the B6 that they're losing. This INH can affect the liver. So you also have to check liver function tests. So while they're on this drug, you kind of have to monitor the liver to make sure that there's no necrosis or anything like that happening in the liver. Does everybody understand that?
Yes.
All right. Okay. Everybody good with TB?
Yes.
Is everybody all right? Good. Everybody's a professional with TB. I think that means yes. Okay. All right. Let's answer this question. Let's see. Have I called on everybody? Let's see. Anna, yes. Richard, yes. Pravani, Deepika. Oh, Vitka. Have I called on you today? I thought I saw Dr. Vitka there. Are they still there? Maybe not. All right. All right. When you get the answer to this, tell me what you all think the answer is.
I believe option B is here.
You say B as in boy?
Yes, with boy because PED-V is more acid stable than PEN-G.
Okay. Does everybody agree with that? Everybody agree?
Yes.
Yes.
Good, because I agree. I totally agree. And I also agree with the explanation. Great explanation. Perfect. All right. So this one right here, this is, I like to say, you start with the letter A, and if A doesn't work, you go to letter C. All right. Everybody hear what I just said?
Yes.
Yes.
So you start with A, the letter A. If A doesn't work, then we go to C. So what do I mean by that? So if you are prophylaxing, right? Prophylaxing, you start off with amoxicillin. That's the letter A. If they can take it by mouth. If they can't take it by mouth, then you go with the ampicillin. And we're still talking about the letter A. Now, if they're allergic to penicillin, then we go to the letter C, from A to C. That's cephalexin. What is cephalexin?
Cephalosporin.
Which generation?
First.
First.
Very good. Very nice. Wow. You all are remembering all of this, right? All right. What is azithromycin? How does it work?
It's a macrolide.
Macrolide.
Uh-huh. And how does it work?
And if you-
Mechanism of action?
50S.
50S ribose.
Perfect. Very perfect. Good. How does clarithromycin work?
Same 50S.
Okay. What is doxycycline?
Tetracycline.
How does it work?
30S.
Isn't it? Now, didn't I tell you pharmacology was easy? Isn't it simple? You all are just, huh?
Now it is.
You all are not, y'all are doing this like so easy. So we go from A to C, right? Well, so cefazolin is also a first generation, right? But the only thing that you want to remember is the dosing. Remember the dosing. The letter 2 is easy to remember. 2 grams. 2 grams, right? 2 grams. Okay, everybody see that? So for the most part, it's going to be 2 grams. Now, in children, it's going to be 50. Remember the number 50. 50 milligrams per kilogram because you're doing body weight. Does everybody understand that?
Yes.
Yes, sir.
Yes.
Okay, good. Now, I could go further down here, but honestly, you really won't get down that far. Your answers are going to be somewhere up in this area, okay? Now, look at this right here. What do they say about clindamycin? Why is clindamycin no longer recommended?
C. diff.
C. diff, right. Because of Clostridium difficile, which can lead to what condition?
Pseudomonas.
Pseudomonas colitis.
Perfect. Very nice. Very good. Outstanding. Okay. Wow. Now, I didn't know you all were going to do that well. We are finished with the antibiotics. Wow, that was pretty good. Normally it takes me a little longer, but you all flew through that like it was no problem. Does anybody have any questions on those antibiotics?
I have a question.
Yes.
We talked about everything about the penicillin group of drugs in case of penicillin resistance.
Uh-huh.
Do they ask questions about penicillin resistance, and what is the last drug that we can use in cases of penicillin resistance? I read
Yeah.
somewhere that it's vancomycin. Is that true? That's the last drug that you can give?
Yeah, so I think so. What you're asking is in terms of, so you're saying like if the patient, are you asking if the bacteria is resistant to penicillin?
Yes. Mhm. If
Yeah.
it has developed resistance to penicillin, do
Right.
they ask questions on that?
Yeah. So vancomycin is such a last resort. And the reason why is because vancomycin gives you really some really nasty side effects, like what we call the red man syndrome. It's really a bad flushing of the skin, metallic taste in the mouth. So vancomycin would like be the last choice. You before you even get to vancomycin, you're going to be definitely somewhere in the cephalosporin area.
Okay, so cephalosporins will be the next choice after penicillins.
Absolutely.
And it keeps going higher and higher in cephalosporins then?
If you had to go, but if you think about it, there's not too many instances where somebody's going to be allergic to a penicillin and a cephalosporin.
Yes.
So the only thing that I would say that you would probably have to use a different antibiotic for is if you're looking for a different mechanism of action. See, all three of those that you just named all have the same mechanism of action.
Right.
So if you needed something that specifically targeted, like say a 30th unit, then you might have a different choice. But for the most part, you're going to be at a penicillin first, cephalosporins if the penicillins are, they're allergic, but you're going to be somewhere in that neighborhood.
Okay, thank you. Thanks a lot for answering
All
that
right.
question. I have
You're-
one more question, but I'll let somebody else go and then I'll ask my question.
Well, no, go ahead and ask yours.
Since we talked about the abscess, tooth abscess,
Uh-huh.
so if we have a purulent abscess, and I was reading about the culture, and do we culture first or do we prescribe antibiotics first
Okay.
for the patient?
So I'm going to let you, I think you know the answer. I can tell you, but I think you already know it. So imagine this in real life. They come into the clinic. It's a purulent abscess. Before they walk out the clinic, what are you going to do?
I would definitely drain the abscess and send it for culture and then start them on antibiotics for sure. But
Wait,
my answer,
would you start them on the antibiotic? Like, would you send them home a prescription for the antibiotic, or would you wait for the culture to come back?
I mean, the culture takes at least 2 days and patient will be in severe pain. So I would put them on the basic like amoxicillin and wait for the culture to come back to improve my treatment. That's how I would think. But I'm not sure if that's the strategy that's being followed here. But
What do you all say? What did the other doctors in the group say?
So I wouldn't prescribe antibiotics. I would give incision and drainage, and I'll be like, could you get back in like 2 days for the results to come back? And if I'm sure that it's a bacteria, or the type of antibiotic that I need to prescribe for the patient, and the culture should match before prescribing it, so that I'm not like, giving a wrong prescription for the wrong antibiotic. So
I would prescribe the antibiotic first, and then when the culture and sensitivity comes back, I'll, change the antibiotic if it's needed.
Okay.
I will do the drainage and I'll give them some painkillers like Tylenol or NSAIDs. And by the time the culture come back, we can put them on antibiotics.
Okay. Wow. Okay. I heard some different, some different things. Okay. So here's my question. What is the harm? Is there a harm in giving an antibiotic, like an empirically given an antibiotic before the culture come back? What's the harm?
So it could target non-pathogenic flora of the oral cavity, and then it would change the flora, which could also affect the patient somehow.
Okay. Now, one thing I heard that everybody said, or I didn't hear that you all said that I'm glad you didn't say it. Nobody would give the antibiotic prior to culturing, right?
No, I would give the antibiotic prior to culturing, but after the culture comes back and if we need to change it, because of the sensitivity to antibiotic, then I'll change it.
Uh-huh. Now, if you give the antibiotic prior to culturing, is there a chance that you could miss something?
There is.
Okay. All right. All right. So here's the rule of thumb in terms of antibiotics. So empirically, you can give antibiotics if you suspect what it is. When you culture, you typically shouldn't give the antibiotic prior to culturing. And the only reason why is you don't want to mask something else. Does that make sense? So if you give it, so say for instance, you come in, you culture, and then you send them home, and you send them home with antibiotics. You've already got the culture before you did the antibiotics. Does that make sense?
That's exactly what I meant.
Oh, okay. Okay. I thought you were saying you coach, you give them the antibiotics, and then you culture.
No. When they
Okay.
come, we do that, and then you send it home with the
That's
antibiotic.
perfect. That's right. That's exactly the way you approach that. Good. All right. Does anybody else have any other questions?
Hold on, I'm sorry. So what is the answer? Do we send the patient home with antibiotic, right?
Yes.
I'm
Yeah.
not
Yeah.
feeling-
You can definitely go ahead and prescribe them antibiotics, but make sure you get your culture first.
Okay.
Thank you so much, Dr. Sutton.
Absolutely.
I had a lot of confusion regarding this. Thank you so much for clearing it.
No problem. All
My
right.
fear of pharmacology is significantly reduced with your help.
Well, hopefully it keeps going down. So tomorrow we will be doing our antifungals. Yeah, we'll cover the antifungals and the rest of the antimicrobials. And then I think we have the bisphosphonates on Wednesday. So tomorrow, now tomorrow we're scheduled to meet at 7. We're gonna stick to that because I want to teach that. I do have somebody else who is gonna teach it for me because tomorrow's my birthday, but I'm gonna teach it. So I'm just trying to think. Is everybody on the same time zone in this group? Are you all? Is anybody?
No, I'm 1 hour behind.
Oh,
Then-
what state are you located?
I'm in Florida.
So
And happy birthday to you. And my birthday is in Thursday.
well.
but I'm
Look
also-
at happy birthday
I'm-
to you.
For some
Thank
cases,
you,
for
but
some
I'm also
cases,
gonna make it here.
Well, look,
I'm
we're
gonna
gonna
say,
be working on our birthday. That's okay.
tomorrow
Okay.
is my birthday too.
Tomorrow's whose
Oh,
birthday?
wow.
Edward.
Your birthday's
Wow.
tomorrow?
Yes, absolutely.
Oh my
Happy
goodness.
birthday. Yay.
Wow. See,
Party of
Edward, I knew there
power.
was something. I knew there was something I liked about you.
Oh,
That is awesome.
likewise.
Awesome. Well, listen, we'll have a birthday party tomorrow online. So we'll be here tomorrow doing a birthday on antimicrobials. So
Amazing.
I will see you all tomorrow. We'll be here at the same time tomorrow at 7. And just go finish the antimicrobials, okay?
Doctor, sorry to cut you off. Correct me if I'm wrong, please. I was pretty sure that next lecture is gonna be on Wednesday.
Oh, wait, let me look and see. Hold on.
Please.
Hold on
elaborate
one
on it.
second. Let me share my screen and make sure we're all on the same page because I do not want to mistake that. Okay, hold on a second. Okay. All right, I'm gonna share my screen with you. Tell me if this is the same thing you see on your screen. And if not, I make sure, and maybe it might be right. I don't know, because I'm surprised that they did schedule it on my birthday, but I didn't mind, it didn't matter. but let me just check and see. Okay, can you all see my screen?
Not yet.
Not yet.
Yes, now I can.
Okay, so what I'm looking at, wait a minute. So
Or maybe it's another group.
no, so okay, so right here, no, I see. So actually with both groups, so we have, so right now in this group, we have some people who are from the August and some people from November, the people that just started. Am I correct?
So in my schedule, I'm looking at my calendar, and according to it, we are doing the next lecture on Wednesday, 16.
And what lecture is that?
Bisphosphonates.
Okay.
I have antimicrobials with Dr. Patel,
Who's now? Who is
tomorrow.
that? Who's saying that?
Sophia.
And Sophia, you're with the August group too, right?
Yes.
That's
So I
yeah,
have
that's
tomorrow antimicrobials with Dr. Patel. If I
right.
pronounce
But
it right.
yeah, but
And
I was gonna do the antimicrobial. Now he was gonna do them, but I think I was gonna tell him I was gonna finish it since I started it. But I thought I had that on there for there. Anybody, Pooja, you're in the November group, right?
Yes,
So what does your calendar say?
it says with Dr. Patel.
Okay. So I'm not sure, Edward, why yours says Wednesday. You don't see Tuesday?
Nope. Nope.
That is very
I've been attending all the course on Mondays and Wednesdays.
right.
yeah,
No,
Edward, by the way, you missed one lecture last week on Thursday. There was an extra one.
yeah. So remember, so with the group, there for the most part, your classes are on those days, but there's some days I think we mentioned earlier that we would have a class that may be on a Tuesday and Thursdays also. So that's why we said just make sure you follow the calendar, but it doesn't happen often.
So what are you gonna do?
Yeah, so we do have the antimicrobials scheduled for tomorrow. And I'm okay with still teaching that tomorrow.
I won't be able to join tomorrow. Sorry for that.
Oh, okay.
How do you join?
I scheduled my days really.
I'm with you. I'm with you.
Can you,
Well,
can you send the
I'm
link?
with you.
here's the good news. The good news is you all have me all week.
Yep.
So
Yeah.
so you all have and this is why I love, making the groups not too big. You all have the option. I don't mind doing Wednesday, Thursday, if that's okay with the entire group. I don't mind meeting tomorrow. I am very flexible. So like I said, you have me all week. So you all just let me know.
And very quick, are we meeting on Wednesday with a biphosphonate lecture?
Yeah, so we still have to finish the antimicrobials, and then we have the bisphosphonates next.
I see.
So, but I would need to get a consensus from the group.
I see.
Can we do it on Thursday?
On what day?
I don't know. Do we have a choice?
You have a choice in terms of this week we're going to cover everything we need to cover. So the only choice that we do have is that if we did not, because I'm looking at the schedule, we have to finish the antimicrobials, and we have bisphosphonates and then analgesics. So the only option that we would have is if we did not do the antimicrobials You know what? We got to do that. We got to get that done.
Yes, yes. No, we are
Yeah.
all for it. So we're
Yeah.
meeting tomorrow, Wednesday, and Thursday.
Yeah.
If somebody can send us the link, then we can join because I didn't have it.
So
in
you don't have it either on your calendar?
No, it's Wednesday.
Okay. So what I'll do is I'll have Elaine make sure that she also sends the link in addition to making sure it's posted on the calendar. But so we'll meet tomorrow. Edward, if you look at the recording and if there's something that you see in the recording that you don't understand, just send me an email and I'll get with you.
Yep.
Oh, as far as the recording, how do we get to the recording? That's what I was trying to.
Yeah, just email Elaine if you don't have access, but you just get to the recordings through the Google Classroom.
Okay, I didn't get
But if
one.
you
Okay.
email Elaine, she'll send you the link.
Thank
And
you.
how long is the recording is going to be available for us after the course is done?
So depending on which level you are, you have at minimum you have 2 months, but if you're level 3, I think you have up to 6 months.
Okay.
Just if
Oh.
you email Elaine, she'll know. She can tell you exactly what you have. Okay.
Okay.
All right.
All
Okay.
right.
I have
All
a
right.
question about tests.
Yeah. Uh-huh.
After, do we take the test after we are done with the class, or do we take it before the class?
You mean the quiz class marker?
Yes. Mhm.
Yeah. Once we have to complete the topic. We're still on antimicrobials right now. So
Yes.
yeah.
Mhm.
When we finish the topic.
Okay, sure. Thank you so much.
Okay. All right. Okay. Well, I will see you all tomorrow.
I'll see you then, and
Thank you so much.
happy upcoming birthday, you all guys.
Happy birthday to you too.
Happy birthday.
Happy birthday,
All right.
guys.
Thank you
Happy
all,
Sutton
and see
and
you.
Edward.
See you then.
All right.
Appreciate it.
Bye-bye.
Okay, bye-bye.
Bye.
Bye,
Bye.
guys.
Good night.